start today's very interesting panel discussion now. And for the panel discussion, we are really delighted to have with us Cornell Professor Prafull Mohan, who is the professor at the Department of Pharmacology at AFMC Pune. He is also a clinical pharmacologist and his DM in clinical pharmacology. So I want to hand over him, and today's panel discussion is on bridging the ancient wisdom with modern medicine. So may I request Professor Mohan to introduce your panelist, and let's start today's panel discussion.
So thanks a lot, Dr. Shambhu. I hope I'm audible. Can somebody confirm that to me?
Yes.
Yes.
Yes. So thank you. It's been a fantastic listening to the wise words from very illustrious speakers. And when this opportunity to moderate this session came to me, I was having some kind of a trepidation because this is kind of an abstract topic, and the context and confines of this topic cannot be easily defined. But when I look at the panel and the panelist, I was really thought that it was my privilege to engage with such illustrious leaders. We have with us today Dr. Nirmala Rege and Dr. Nilima Kshirsagar, who are pharmacologists. And then we have Dr. Anuj Maheshwari, Dr. Tripathi, and Dr. Shyam Sundar, who are eminent clinicians who do not require much of introduction, and their eminence is, known to all of us. So, as Dr. Shambhu has informed us that the panel discussion is about bridging ancient wisdom with modern medicine. So, what I'll do is I'll kickstart the discussion with each member of the panel, and maybe pose a poking question to them, and then we see how we go about. I purposely have not kept it too structured so as to ensure free flow of ideas and to draw, cogent lessons. So, what I'll do is I'll introduce each panelist as we go on, because let's say if I introduce all the panelists now and one of the panelists is speaking at the end, then the pertinence to audience is lost by the time the I would say the opportunity for that panelist comes to speak. So the order of, I would say, the order of the speakers in the panel, as I'm approaching them, is not necessarily in their order of eminence or age or knowledge. They're all doyens in their own fields, and we look forward to have a lot of gainful insights from all of them. But let me start this with Dr. Nirmala Rege. So before I go ahead and pose a question to her, I would want to give a brief introduction without costing without having a big time penalty. Dr. Nirmala Rege is a very eminent and famous pharmacologist whose name is known to almost all and everyone who has studied pharmacology in whatever I would say capacity, maybe as a UG student or a PG student. And of course, to PG student, she is also known as a very ingenious teacher, if I may use the word. Her eminence flows out of the fact that she has published multiple books, widely read, widely acclaimed. She has about 125 publications to her credit and more than 40 research awards. Currently, she is working as professor of pharmacology as IRA's Lucknow Medical College. She is also professor emeritus at pharmacology department at State GS Medical College, and she has been a past president of Academy of Health Professionals Educators. So her core areas has been in pharmacological research, pharmacological teaching, and also medical teaching as an activity. And she was also the faculty for State GS Medical College, Fimer Regional Institute. She has been principal investigator for multiple Ayush and ICMR projects. As I have told already, multiple publications and books to her credit. So, Dr. Nirmala Rege if I may attempt to ask you a question, ma'am, most of the times you have been asking questions to us, being our teachers. But let me take this opportunity to put, the go on the other side of the table. So we all know that you have worked extensively on developing plant products into modern medicine avatars. Can you briefly summarize your experience, maybe with reference to maybe one particular plant or one particular plant product, and uh, kindly identify two, three crucial bottlenecks that you had to face in your journey during which you were studying the plant products and trying to bring to fore their pharmacological properties in the context of modern medicine. So, Dr. Nirmala Rege, please.
Yeah. Am I audible?
Yes, ma'am.
Yeah. Thank you, Dr. Mohan, for that introduction, and thank you, Dr. Shambhu, for inviting me for this particular session as per and this CME. Uh, uh, I will. There are very few products in which, as you said, that I help in developing them into modern avatars. Most of my work is related to validating the claims about those products in Ayurveda, or finding out the mechanism of action, the pharmacological way. But the one I would like to talk about our journey with Tinospora cordifolia, and I owe all this research, whatever I've done, and I've assisted my guide, that is Dr. Sharadini Dahanukar, who had learned Ayurveda. And this is the one we went in a very keeping the Ayurvedic, whatever is mentioned in Ayurveda, keeping those things in mind, we processed it. And our pharmacological knowledge, it helps in developing it. It is with Dr. Dahanukar and Dr. Urmila Thakte, who is an eminent pharmacologist, a clinical pharmacologist as well. So it started actually from Ayurvedic concept, because this is the plant which has got multiple actions and multiple uses mentioned in Ayurveda, and it is very difficult to say why or to explain all these things. But the property of this plant is a rasayan, and Dr. Dahanukar tried to decode this rasayana concept. So actually in Ayurveda, that rasa means the primordial tissue, means all the tissues they start from rasa, and iron is a path or the way. So this rasa dhatu, that is the tissue, it influences all other tissues. So whenever whatever the drug improves the quality of the rasa, would strengthen the all tissues. That was the first thing. And the second thing, when we looked at Charak Chikitsa, it was mentioned that all these rasayana are used for Vayastapanam, Ayurveda Balakaram, and Rogapaharanam Samartham. So Vayastapanam is the anti-aging, Ayurveda Balakaram is increasing the longevity of life and strengthening the learning and memory. And Rogapaharanam Samartham, we concentrated on that. That is the removal of the diseases. Now, what we did with her this thing, we had a concept, because everything starts with hypothesis when we do. So our hypothesis was how this happens, and that time the psychoneuroendocrine immune axis we were learning a lot. So with some preliminary experiments, we thought that these rasayanas are stimulating immune cells, which is responsible for the cascade of events, which is responsible for this multiple action. So we went in developing various preclinical models, as we all our pharmacologists do, various models of infections induced in animals, and we found that the animals treated with Tinospora cordifolia, they survive more. And then we took the serum of these animals to see whether this particular drug has an antibiotic-like effect, but we didn't find. And therefore, we concentrated more on the immune cells. We did lots of in vitro and in vivo studies to see the effects of PMNs, polymorphonuclear cells, macrophages, monocytes, peritoneal and alveolar reticular endothelial system. And overall, we found that they increase the phagocytic and intracellular killing activity. We didn't concentrate much on the T cells, though we did few studies on the T and B cells. And then with this, we decided to go for human models. And the model we selected that time was obstructive jaundice, because Dr. Ravi Bapat, who was an eminent gastroenterology surgeon with us, was working. And we have done some studies with the patients with obstructive jaundice, and we found that they are immunosuppressed, especially their polymorphonuclear function is very, very poor, and there is a decrease in the percentage phagocytosis. So we kept that as an indicator. And we treated these patients. We did multiple studies with them, and we found that there is a difference in the mortality. The more people survive, as well as there is a better percentage phagocytosis of their polymorphonuclear cell. And with this concentration of number of studies, we found there is a decrease in endotoxemia. We found in vitro studies, they increase the Kupffer cells. The most important thing we found that they activate the PMN cells or the macrophages, that there is an increase in GM-CSF. And we established our dose response relationship. We did the studies on INU. And after this, we went to another disease, Dr. Maheshwari. He's a chest medicine physician working with us that time. And we studied the patients with on anti-tuberculous drug. And we found there also, because the macrophages are very, very important for in case of tuberculosis. So we found there is an improvement in clinical symptoms. There is a reduction in sputum conversion time. There is a hastening of the radiological recovery. And we also did studies with Dr. Rajan Badwe at Tata Memorial Hospital in patients with breast cancer. And that time, CMF, that is a cyclophosphamide, methotrexate, and 5-fluorouracil. They were the chemotherapeutic agents of choice in those days when we did the study. And we did, when the cycloid analysis, we found there is a reduced neutropenia. And all these studies we went with the help of pharmaceutical company. There was a pharmaceutical industry was with us, which helped us in developing the formulation. It was a whole aqueous extract we used for all these studies, and that was Merin. And then it was taken over by Woka. So this came as an indigenous immunostimulant in the market, marketed by Woka. And this particular Tinospora, which fascinates me, because I keep on reading about it, and there is so much of work which is going on. Even we have done some studies, and we have found that it helps in improving the gut barrier also. We have seen that it helps in decrease that antibacterial resistance. It is useful in that. It has anti-cancer properties, which we have not, though we have not studied. And currently, with Dr. A.B. Vaidya's team, we are working with Dr. Vikram Gota at ACFEC in solid cancers to find out expanding it to what we have seen in breast cancer, whether it helps as an adjuvant for the care for the patients who are undergoing chemotherapy. So that is how that is a one particular plant. And there are, if you Google with our names, you will find all these references what we have done. But if you ask me the bottlenecks in this particular journey, our bottlenecks were mainly finding out the right model and going ahead with it. We didn't face much problem except for the determination of the dosages, because it is very important when you decide, you are extrapolating the doses from the animals to human being. Of course, when you are working in the Ayurvedic product, you have an advantage, because there are doses which are mentioned in Ayurvedic textbooks, and you can extrapolate directly from those human dosages. But when we are using the extracts, and we have to keep that in mind, whether we are using the dose of the extract, how we are going ahead that, or crude extract. That is one more thing. But more than that, in another study, I have found that where multiple plant products one is using, that standardization and the quality control is very, very important. How you can, because when you are mixing multiple plant products, it is very difficult to get with that fingerprinting changes as you all those phyto ingredients, and they have very common phyto ingredients. So you can't have the unique fingerprint like you get for the chemical products, our drugs. So whenever you do HPLC or HPTLC, more you mix, you can't compare with the original one. And one has to be very careful, and you have to have phytochemist, good phytochemist with you for the standardization and quality control. And when you want to do the placebo control studies, the making of the placebo is very, very again important. To make a placebo for a plant product is a very difficult thing unless you are using the capsulated form, because their color, their odor, they can influence me. So sometimes the people give us placebo, and we have seen in one of the study that the placebo contained the active ingredient, because when we went into details of that, we learned that they have extracted all the active ingredient. That's what they felt, and that remaining mark was given as a placebo. But in fact, that placebo had active ingredient. And luckily, we used to do HPTLC of any given product in our laboratory. So we did that, and we could point out that there is an active ingredient. We did animal studies prior to the clinical studies, and we found that there was a response in those animals given placebo. So yeah, we told them, and then they have to improve it. Otherwise, that clinical study would have been disaster. And third thing is, you have to be very right in the beginning, because when we developed Inospora cordifolia, the regulations were simple. Now you have to decide beforehand whether you are going for the Ayurvedic drug, whether you are going for the phytopharmaceutical, or whether you are going as a US botanical. And the data which you have to generate for all these three things is different. So you have to be very clear in the objectives, and that could otherwise, when you proceed with one pathway, there could be a bottleneck. Thank you.
Thanks a lot, ma'am, for abridging your rather long journey. We know that you have sort of shortened it quite a bit, and
Yeah.
I'm sure the journey must have been, and I'm sure it is still continues, being rough
Yeah.
and with a lot of gradient. So, I'll invite the audience also to pose a question if possible by way of chat. Can the virtual administrators ensure that we get the questions, if any, from the from the audience?
No, not
From the
yet.
chat.
Not yet, not yet. You please
All
carry on
right.
the panel discussion. We can take the.
All right, fine. So, ma'am, just one question from my side.
Okay.
That the effort of bringing traditional medicines or plant products into modern medicine fold is clearly a multidisciplinary effort, and one person may not be able to make a huge difference. Of course, the passion and leadership are the pivotal things which you have been providing, of course. But in your opinion, is there any one technology or a platform which you would say or opine on that if that increases, if that percolates down, like in case of therapeutic drug monitoring, we say that if we have more number of HPLCs and LCMS, then the cause of TDM will get furthered. So, if I may use this analogy, in terms of development of traditional medicines, do you feel that there is any one technology which needs to be, upscaled or made more pervasive so that efforts like you have been doing can be undertaken by multiple people?
No, no. As you rightly said, that it is a teamwork, and each member is important, because it is not the quality. Again, I'm emphasizing on the quality of the product, because it is not the quality at the end. It starts from how you have collected that particular plant with plant specimen, leaves, which season, what is when for Tinospora cordifolia, the thickness of the stem, for that matter. Uh, everything is important. So you can't have rely on only one technology. which will help you. But it is always a joint collaboration that what you have said is more important, I feel. Continuous discussion, meticulous planning, and how you are going ahead with that. At each and every step, the person is important. The cellular techniques, the preclinical models, and the clinical studies, of course. So without clinicians, you can't do. Means only pharmacologists can't do. So all these three the people means these people as well as pharmacy people, phytochemists, everyone is important. For botanists, everyone is important.
Right. Thank you, ma'am. Thanks a
Yeah.
lot. There's one question on chat which we have received from Dr. Avinash Kinikar, and he is asking that are extracts of Tinospora curcumin safe compared to Rasayan described in Ayurveda as far as liver functions are concerned? So
Yeah.
maybe a brief comment on that.
Yeah. The recently there are which type of extract, that is very important, because Ayurveda doesn't. I have seen many pharmacy people using the extract like petroleum ether extract and all. So Ayurveda doesn't advocate those type of. In Ayurveda, if you look at the extracts, they are aqueous extract, hydroalcoholic extract to some extent, and there are some alcoholic extracts which have been used for some formulation. So you have to do the studies. But recently, if you go and do the literature search, you will find Dr. Abha Nagral's the article has appeared. I think two she has published, and there were the case reports that there has been some injury, and which is immune related, and because of the Tinospora cordifolia, the way the patients have used. Everyone has used different extract, and all of them didn't use the same this. So you have to be very careful. When I'm saying the drug is immunostimulant, you can't use the drug the way you want it. At the same time, one has to do the studies to see, because the Tinospora cordifolia is something which is advocated in Ayurveda for young children also, from infants as well as older elderly people, and the usage is so much. So actually, at the national level, the studies have been taken to find out what is the usage, how many patients are getting liver damage, because the drug is advocated in Ayurveda for the liver conditions. So and say, and we know that for modern medicine also, there are drugs when they are producing effect, they are producing adverse effects as well. So just based on pure effects, we can't say that this drug should be banned or something. But at the same time, we should, and we clinical pharmacologists should develop that data. No one else or foreigners will not come to help us. We have to develop our own data. And for that, the government and Ayurvedic institutions help is required, or collaboration is required.
Yeah. Thank you, ma'am. Thank you. In fact, you have left this last comment as a linker for me to move on to the next speaker, and who is Dr. Nilima Kshirsagar. Ma'am is a leading clinical pharmacologist of national eminence. And I think beyond her actual involvement in clinical pharmacology, her probably the most important stellar contribution still remains in inspiring people like us. You know, it's a long career which we have been seeing from a distance, and very inspirative. Her energy levels are, I would say, exemplary, legendary. And Madam has been the National Chair of Clinical Pharmacology at ICMR. Uh, I mean, the list is rather illustrious and long. I'll just confine to very basic and very, important milestones in her journey. Currently, she is Professor Emeritus at Maharashtra University of Health Sciences. She has been a member of, rather chairperson of Drug Technical Advisory Board Subcommittee on Fixed Drug Combinations. She is a member of FARTO, Pharmaceutical Mission of Government of India, a member of multiple societies, multiple committees of under WHO, and she has been acting vice chancellor of Maharashtra University of Health Sciences, and she has headed the clinical pharmacology department and multiple colleges in Mumbai. Of course, she is also has been the president of Indian Pharmacology Society. having almost 300 publications to a name, and I'm sure the count is still not over. It continues. Like ma'am. So, ma'am, thanks a lot for joining us, and thanks a lot for being here. What I would want to pose a question to you again, reversing the roles. I've been answering questions which you pose to us, but let us have a role reversal for a change today evening. And I would want to ask you that almost all ancient civilizations have their own indigenous medical system. Some of them which died with the civilizations, and some of them continue to grow. And they've been integrating themselves into the modern medical system in varying proportions. For example, we find that Chinese traditional medical systems have been quite well, I would say, rather well incorporated into modern medical system. So, do you think that in our context, this integration has been optimally and satisfactorily done so far? Has it happened? Are we there, or we are not even attempting it? And as a continuation to that diction, can you suggest some policy initiatives which the government has taken or the government needs to take so that the work of Dr. Rege and scientists like her, comes to fruition more fast? So the mic is with you, ma'am, now.
Yeah, thank you very much. Am I audible? Can you hear me?
Yes, ma'am.
Yes, thank you. At the outset, I would really like to thank Dr. Shambhu and yourself for this panel discussion. And I greatly appreciated the presentations from the earlier speaker, Dr. Shashank Joshi, and also others. It was a very enlightening experience for me, and also linking today's this webinar to Swami Vivekananda's Jayanti and also to Kumbh Mela. Great opportunity to consider the integrating indigenous or our traditional medicine into modern medicine. And thank you for that opportunity greatly. When we heard today morning's presentation, I was also reminded of the fact that something which I read, and I thought that's important for us to see, that they said that what is science to technology? One can consider spirituality to religion. So one can think that knowledge and wisdom is something which is so crucially important. And I thought that Swami Vivekananda also commented that all knowledge builds on facts and experience. And on that, we should be building our reasoning. So with that comments from Dr. Swami Vivekananda, I would just like to put my thoughts together in three kind of interconnected points. One is a bit of a historical. The second is what happened. We can connect it to historical. What happens in a clinical situation and how this whole thing can be taken forward for drug development or using the indigenous knowledge for that purpose. I don't want to go back to millions of years or thousands of years of Ayurveda, but just coming to more recent history of pharmacology in India. Dr. R.N. Chopra, all of us know, 1940s, when he's considered as father of pharmacology in India. He had at that time itself identified that the reason for non-response to quinine could have been due to quality of quinine. And in his famous paper that he wrote, and he sort of kind of guided the government at that time onwards, that there should be studies on Ayurveda and to see how that can be actually brought into modern medicine. This is what he actually stated way back in the 1940s. We are all somewhat aware also of Rustum Jal Vakil, and I'm sure clinicians here would remember that, about developing Rezapin from Rovalfia. Excuse me. And he actually carried out clinical trials. That was published in British Medical Journal and very well recognized papers. And he was also sort of recognized by the American Society. With that kind of a background, And you mentioned about the Chinese system. We all know about Dr. Yu Tu, who received the Nobel Prize for her discovery of artemisinin. Maybe I can just digress a bit to say how they have integrated the Chinese traditional medicine into drug development. We are all sort of familiar with what she did. And when they were finding that the artemisinin extract that they were using were giving variable results, then they looked at the Chinese traditional medicine and they realized that if they have a cold water extract, then that is when they get the active ingredient. Of course, we have to understand that they had the full government support and there were nearly some 2,000 scientists working on it, which is what led to the Nobel Prize. In our country, if we look at, I would say that the modern medicine was a bit skeptical. When patients used to ask modern medicine clinicians, we are taking Ayurvedic product, they would not be very supportive of that. But when at our institution, when we were doing our epilepsy clinic with therapeutic drug monitoring, we had found that there is a good deal of drug interaction. And those are the papers that we published, and that is of Shankapushpi interacting with anti-epileptic drug phenytoin. And this was a story of a patient whose we thought that we had adjusted his blood levels of phenytoin. But as he came to the clinic with breakthrough seizures, we asked where we thought he was not compliant and so on. But when we did his levels, his phenytoin levels were low. And that's when he said that he was taking this memory enhancer, Shankapushpi, which was being advertised so widely during exam times. So that is how we had identified that there could be a good deal of drug interactions with modern medicine. They were, of course, then on several other papers which were also published. So while people, patients use, not necessarily always consulting the practitioners, and this question which was asked about use of tinospora and liver toxicity, and Nima very nicely elaborated on that. So this just brings out that it's so crucially important to see what the Ayurvedic literature says about indications and contraindications to use of Ayurvedic medicines. So what Dr. Abha Nagral had shown was, and which is so evident, then later on we all realized that it was probably patients who already had some autoimmune or other diseases. They were the ones who suffered from tinospora liver toxicity. And these would have been in Ayurveda probably mentioned as cautionary to not to be taken. The other thing that happened during COVID-19 is that a very large number of people took immunomodulators because of the huge sort of benefit, and that there was nothing else to do for COVID. So it was also the large number of people that they took and the very long time that Spora was used, which is what resulted into that kind of liver toxicity which was seen. So when one tries to consider Ayurvedic formulations with today's context, these are some of the problems that can come up. That is, you can have it interacting with modern medicine and the Ayurvedic medicine not being used correctly. So as we move along, there was the other always a bit of concern for all people who are trained into modern medicine and scientific thinking, was that the quality standardizations for Ayurvedic medicine was something which was, as described in Ayurveda, was not something which was standing to the test of today's time as we understand chemistry and phytochemistry. That is when there was a considerable amount of effort from all over the world to see how we can do the standardization and have the extract being standardized. A bit back into history again, we all know that CDRI, the Central Drug Research Institute located in Lucknow, they carried out a very large number of studies, but they found that as they prepared the extract and made them more and more purified, in fact, at some times, the efficacy was lost. One of the other things that was noted in Ayurveda was what is called in Ayurveda Shodhana, and that is detoxification of a Ayurvedic plant. This is something which is very important, and some very good scientific studies have also demonstrated this. As we know, when we were students, we were told that a toxic plant substance like aconite, it can be detoxified by boiling with cow urine, which is what is described in Ayurveda. And it was identified at Zandu that this was probably as a result of enzymes present in cow urine, which degraded the toxic components of the aconite extract. Later on, there have been many other studies of plants like Arjuna and also for Ballataka, how this detoxification process can be used, can actually reduce the toxicity by doing animal study. But with all this, still there was not enough of phytochemistry being worked out, although this was quite a lot demonstrated by animal studies of the extent to which toxicity occurred. So this all actually led to the government initially at US FDA and maybe at the EMA, and then even in the our Drugs and Cosmetic Act to come up with phytopharmaceutical idea. That is where a single ingredient doesn't have to be like a modern medicine, like a new chemical entity, not a single ingredient, but sort of extract of the plant, which may be containing more than one active ingredient, but it should be well standardized. And this well standardization, the actual rules, regulations describe that there should be at least 4 components of it which are identifiable by using HPLC. Further, there is a great deal of description as to what kind of toxicity studies need to be carried out and what kind of clinical trials to be done. The US FDA has also defined botanicals. Nima just mentioned that you have to decide as to which way you will follow, whether you will take it through the Ayush route or using Ayurvedic product as it is described in Ayurveda, or whether you would take it as a phytopharmaceutical when you're doing a new drug development. There's also a third aspect, that is the nutraceutical. And sometimes the industry needs to accept nutraceutical because that's easy to do, and it's quite easy to sort of commercialize a product as a nutraceutical in USA and also in India, because it doesn't require such huge amount of studies. But then you can't claim that this will be useful for treatment of a disease. Then it is mainly the claims that are is that it is a health promoter. So with this kind of a background, the CSIR has set up the phytopharmaceutical mission for developing phytopharmaceutical product. And there are some 10-12 substance plants which they are very actively working on it. What, however, I noticed being as a member of that mission, is that there is a great amount of work that is being done in India on the botanical identification. And we know from Ayurveda, and Nima also mentioned about part of it, that depend on which season you collect, which part of India you collect, what soil is there. Needless to mention today's use of pesticides. And there is also, these are being grown also in farms so that they can be developed as required. So we all know about the Google story where, eventually the supply itself a bit ran down because the way it was described in Ayurveda, one could not really have it collected over a long period of time as was described. So the great amount of botanical work and phytochemistry work that has been done. What I think is that here is a great opportunity for pharmacologists to be very actively involved in this phytopharmaceutical mission, and that's work which is being done by institutions like IIIM Jammu and CDRI, and also from Hyderabad Institute. There, the animal model that one develops need to be, I think, linked to the kind of benefit that are seen in Ayurveda. Not necessarily always use the ones which are used for modern drugs, but these should be actually developed depending on what is expected as described in Ayurveda. Similarly, when clinical trials are needed to be done, these also must take into account what is described in Ayurveda, develop the clinical trial protocol accordingly. So I'll just mention here that there is a systematic review and analysis of the clinical trials in botanicals done in USA. And what they find in these clinical trials is that there are problems. And we heard Nima mention about the placebo. There are some of these studies which are double-blinded, randomized studies, but some of them are open label. And then there are always questions about the actual validity of those kind of studies. And when the double-blind studies are done, it's important to see that the placebo is matching and the code is not broken. And then the studies are done as per GCP or good clinical practices, as we today call them. Also, it is important that you take as per modern method the adequate number of sample size, because otherwise you end up in not being able to show the difference. We are considering integration of traditional medicine into modern medicine. So as Prafull just correctly mentioned, that in China, this is very much a part of their considerations now. So I was in China, and you'll be surprised that the way the Chinese system of medicine works, there was a full building, and on the first floor were the Chinese physicians who were actually examining the patient, taking history, and then they were prescribing the medicine. And on the ground floor was their pharmacy, with all various herbs being there in their raw forms, and the formulation was being done there, and it was being dispensed. So this is the way the traditional medicine in Chinese system is being used. There's also a systematic review which has been done again by Chinese people, but they have collected the world literature, and they have tried to see as to how many countries are involved in integrating the traditional medicine into modern medicine. And this systematic review, they found out that there are some 3,000 and odd papers over 10-year time, so about 30,000 papers. Annually, about more than 3,000 papers are being published. And they also said that 30% of these papers were from China, and only 5% were from India. But we should not feel discouraged, because the good thing was that out of these papers, more citation was for Indian papers compared to Chinese papers. So I think maybe we could feel happy that maybe the quality of the Indian papers were better than the Chinese. But this was a very good systematic review, which sort of told us the kind of gaps that although although the government of India has a great amount of push now for integrating traditional medicine into modern medicine, as pharmacologists, as clinical pharmacologists, and as researchers, we need to see how we can contribute by doing good studies which are well validated and using products which are well standardized, and where we can be more sure about the validation. Only then one can consider that one can put this into public health system, which at present we still have a divide between the two pathies. And that is the phytopharmaceuticals expect to overcome that, so that allopathic or modern medicine people can prescribe the phytopharmaceutical, because that would have gone through the more research methodology that we all know about. So I think these are some of my observations and comments. And I would also just like to end up by saying that we heard a lot about Gita, and we said that Shambhu mentioned that many of the times the students face this Sidanti Mama Gatrani, Mukhacha Parishushati. So that is that, I'm feeling really, really low in energy. But then on the other side, the Gita also tells us that Karmanne Vadikaratse Ma Phaleshu Kajachana. So I think commitment to particular activity and taking guidance from teachers and the world leaders. It's something which will no doubt help us to achieve our objectives. And I once again thank for having me to participate in this panel discussion. Thank you so much.
Thank you, ma'am. Thanks for your sagacious inputs. Very quickly, I would just want to ask you one question, if you permit, and that is,
Sure.
I think the maximum integration of traditional medicines and modern medicine, which we see, is actually in the pharmacy shops. Every pharmacy shop, you will find modern medicine, kept in the shelves alongside nutraceuticals. So, it may appear, at least it appears to me, that the proliferation of nutraceuticals is probably low cost, low frills way to bring into traditional medicine into the market without them having to undergo the rigors of, the regulated approval process for modern medicines. So, in your considered opinion, ma'am, I'll request a very quick comment from your side. Should we encourage this kind of practice? Is it coming at the cost of their formal integration to the modern medicine, or
Yeah.
that kind of the shelf integration, if I may say, should we sort of allow it to happen?
So there are three aspects to it, if I may just quickly say. One is the commercial aspect, the other is the scientific aspect, and the third is the social aspect. So you will see that the patients always want to have something, kuch to de do. If the doctors say that आप सब ठीक है, कोई किसी की जरूरत नहीं है, they are a bit crestfallen and dissatisfied. And the commerce always come into picture. If you look at the US FDA botanical, from China, there were 500 applications, out of which only 2 US FDA approved some years back, and then that is increasing. And comparatively from India, there were not many. Of course, it's all quite a lot depends on the finances available. But I think that from an Indian science perspective, we need to see that we do in a very good scientific manner studies, so that sometimes it is done to substantiate or validate observations from Ayurveda, but often developing a new drug which is well standardized. There's also sometimes as also mentioned by Nima, there is repurposing also. I mean, what is described in Ayurveda can be further taken forward, because the diseases described in Ayurveda, the wordings and the symptoms are though quite well aligned to modern medicine. Diagnosis is something different. We have many more methods of, now diagnosing. We still haven't touched on, which is, I think, the time is not there for us, is the importance of artificial intelligence and machine learning. What that is going to, where that is going to take us when we talk about developing drugs from Ayurvedic sources. But I'm sure that will add a completely new dimension and level to all the work that we do. Thank you.
Right, ma'am. Thanks a lot, ma'am. And thanks a lot again for leaving us with a linker to the next speaker. That is the diagnostic, or I would say the evaluational approach to a patient in modern medicine vis-a-vis the traditional medicine systems. So it's an honor and a privilege to have on board Dr. Kamalakar Tripathi. Sir is a very eminent clinician, and he has been professor and head of the Department of Nephrology in Varanasi University. And suffice to say, I think one of the biggest markers of his eminence is his recognition by the government of India, who conferred Padma Shri on Sir. And Sir has had almost 300 publications. He also holds a Guinness Book of Records in 2013 for enrolling maximum number of diabetes mellitus patients on a single day on a single site. And he's been examiner for more than 10 national universities, have been project officer, research officer for ICMR funded projects for almost 30 years now. And he is a fellow of Royal College of Physicians. I'm at a real risk of missing out some of Sir's, I would say, accolades and achievements, because the list is really long. But I'm sure Dr. Tripathi will pardon me on this. And Sir, if you are there, can I ask a question, a teaser question to you? Is Dr. Tripathi there?
Sorry, I couldn't listen. It was off for a while. Can you repeat the question?
Yeah, sir. So I've just asked. I'm going to ask you a question now. I was just trying to
Yeah.
inform the audience about your eminence. So, though of course that requires no, I mean, a lot of people are aware of your eminence and sagacity. But so, just to broaden the context of the discussion, I would like you to pose. It's not a question, maybe call for your inputs. That how do you feel that the approach to a patient when he comes to us, how it has undergone a change from the traditional medicine systems to the modern medicine? As a very basic level, as I understand, we are trying to become more objectivized about everything. We want to know the exact measure of the blood pressure, exact measure of the blood sugar, maybe quantify fever, and then treat accordingly. So was it like this before? पहले भी ऐसा ही था क्या? And the concept of Vata, Pitta, Kapha, and Nadi, which have been touched upon by previous speakers, is there a room, or should we incorporate all these systems formally into our assessments of patients as we go on? And were the previous approaches, which were probably more subjective and experience based, better than what we are doing now? So it's a little open ended question. Pardon me for that, but I'm sure we'll all get benefited by your inputs.
In Banaras Hindu University, there is a two faculties, separate Ayurveda and modern medicine. And in Ayurveda faculty, there is a Kaya Chikitsa, means the internal medicine. And in that particular department, there is a one complete paper which talks about which is modern medicine. The examiners are from the modern medicine side, and the thesis and also is co-examined by them. So there is a system of teaching exclusive. Many times CCIM doesn't recognize them, say, no, this is wrong. But we, right from the days of Pandit Madan Mohan Malviya ji, who introduced the system, in 1980, 1928, when the university took as a recognition of Bachelor of Ayurveda Medicine or Master of Ayurveda and Surgery, then at that particular time, there were teachers from modern medicine who teach exclusive modern medicine, the biochemistry. The teachers who from pharmacology would talk modern pharmacology, but the student will learn it, may not practice, may practice. So that was the reason. And since then, there has been a tradition of making diagnosis. You said rightly. In Charak Sanghita also, in Ayurveda, there is a Nidan Sthanam, Sharira Sthanam. So they talk first about the biology, the cosmic biology, the eternal biology, the cell biology, and having completed that part, then they talk of Vata, Pitta, and the Kapha. So this what we call loosely Vata, Pitta, and Kapha. This is from the part of the genesis of the Kapil Muni Sankhya Yoga. It's a small part is represented in Gita. The Sankhya Yoga means how this body was constituted in the mother's womb, and how did these supernatural powers, the light, the energy, the source, they contributed into the constitution of the body. And with this, because imbalance between the three, you got the disease. This is called samprapti in Ayurveda. Like we have the natural course of the disease, we have incubation period, then we have a progression of the disease, and then we have intervention and the result. So Ayurveda is a very brilliant clinical science. So is a subject of very intelligent people. See, in one of the professor of Ayurveda, whom I met lifetime, he studied first the Vyakaran, the grammar. He did his post-graduation. He did his another post-graduation in the Jyotish, astrology. Another post-grad, Acharya means what? Then he studied literature, the Sahitya, the Karma Kand, the Mimamsa, and then he decided now this is the time I must read Ayurveda. So that is the prerequisite of Ayurveda. Therefore, what happened, most of these Vaidya who were initially, they would pick up the Nadi Gyan is not a pure Ayurvedic part. This developed during the period of Tibetan, during the Buddhism period, because that time the border were opened from the Takshashila right to the Nalanda. There were people going here and there, and lot of description in Ayurvedic diagnostics skill has been taken from that particular literature. So Jivak was one who also had a skill of surgery. He was a Buddhist, and like Jesus Christ, Buddhist also had that miracle. Miracles were done only by the Buddhism during Buddhism time, by the Jesus Christ and all those period. There were that sort of change which would occur, touch the person, take away the pain, but this was not present in the Ayurveda. So taking the pulse, looking at the pulse, the temperature, the abdomen, the eye sign, all these signs have been described in Ayurveda. And because they have been described in Ayurveda, they are the clinical interpretation in the Rog Samprapti. So if you want to prescribe a pure Ayurvedic medicine, you need to have a pure Ayurvedic diagnostic skill. You cannot ask modern medicine man to make a diagnosis of status asthmaticus and ask the Ayurvedic person to do it. It could be other way around. It could be sometime detrimental also. For example, patient may have a left ventricular failure, and an Ayurvedic physician might be thinking of tamak shwas. The shwas means the patient has a severe exacerbation and obstruction of the COPD, and the COPD is deteriorating. And because of this deterioration, patient have trouble. So diagnostics should be made separately. Accordingly, drugs should be prescribed. And then what Madam was talking before also, in Ayurveda also there are three different type of the drug preparation. One is called Sattva medicine, Kashtaushadhi, where it excludes a plant tradition. Second is based on the chemical compound, organic compound, means heavy metals, mercurials, shilajit, parad, gold, abrak, all those which is also used in the Ayurveda as a stimulant. And these are the drugs are used for a different class of people. And third is the tamasic, the one which is used with the animal preparation. And these animal preparation are usually made for the warriors, those who go for, they get the war injury, they get the emergency, and for those people. So according to your body constitution, the drugs are to be prescribed. In Ayurveda, there is a description. Because people do not read completely. So, Charak Sanghita, you need more than the Gray's Anatomy. So you need completely a discourse on it, and each and every chapter to be read with that spirit. So what I feel that you need a Ayurvedic diagnostic way, constitution, according to the constitution, then they have the Chikitsa Sthan, Nidhana Sthan means diagnosis, then pathological process, Vikriti part, then they have also according to the Samprapti of the disease, and then having done all those, then you write a prescription. And then you select a drug, choose a drug. If this is followed, Ayurveda will certainly grow. Most of the people do not follow this. That's one A.
Right, sir. Thanks for your inputs. I just wanted to pose a question to you, sir, and to seek your opinion about this. So, as you said that even Ayurveda, the way it is practiced by Ayurvedic physicians, is not optimally, backed up by
Agree.
the knowledge resources, which is as important. So, in that sense, it is again sort of half cooked, if I may use the term. So, do you feel that there is some scope of exposing the modern medicine students, MBBS students, formally as a part of their curriculum towards these concepts of Ayurveda? Of course, the entire text
I'm
cannot be taught to them. So will it be good? Will it help them in incorporating these aspects when they become practicing clinicians? Or we should allow both the systems to, grow separately and then maybe integrate at a later date?
few area is certainly important in that sense. And like degenerative diseases, osteoarticular diseases, the diseases which do not kill the patient but make lot of incapacitation.
Yeah.
See, we have accountability to the society. When you have a modern physician, this person has a lot of bindings on the social bindings, legal bindings. So he cannot just go out of break all the things and practice medicine according to his will and wish. But there are certain areas where these drugs could be. For example, those patients who have a chronic irritable bowel syndrome, and you have done the exclusion that there are no neuromuscular disorder, there are no serious metabolic component, patient does not have a structural deformity, patient doesn't have a disorder of the mesenteric plexus, neuromuscular mesenteric plexus diseases, then you use lot of adsorbent. These are the not absorbent, adsorbent. Then they regulate the bowel, make the bulk, set up the absorption, and take away detox like
So we have lost your voice, it seems. So we appear to have lost your voice. Yes. So I think there is certain signal issues at the end of Dr. Tripathi, but nevertheless, thanks for his inputs, very sagacious inputs. Uh,
oh,
Sir, are you there?
I think you can move towards the next panelist.
Yes.
First.
Right. So next, I would want to go on to Dr. Anuj Maheshwari. He's
can you listen
currently
me now?
Yes, sir. Sure, yes, sir. Hanji, sir.
Yeah. Sorry. It was disconnected. So what I mean to say, you need a different way of diagnosis also. But for modern physician, there is a group of diseases which is non-communicable and non-metabolic, degenerative. You can prescribe Ayurvedic medication, and there are known method of action for these drugs. These are the non-toxic drugs. These are the Kashtaushadhi. They are not heavy metal, and they have got their own positive scientific role. So these drugs can be used.
Right, sir. Thank you, sir. Thank you. Thanks a lot for your sagacious inputs. It was really a pleasure to hear you, sir. And we have heard a lot about your eminence, but thanks a lot. It was first time I was hearing you in person, though virtually.
Thank you. Thank you.
Right, sir. So now I would want to go on to the next speaker, who is Dr. Anuj Maheshwari. Dr. Maheshwari is currently Professor of Medicine at Hind Institute of Medical Sciences. Again, a very eminent person. He is the governor of Indian chapter of American College of Physicians, also the president of Asian Pacific Society of Hypertension. And he has been recently elected as the president-elect of RSSDI for next 3 years. And sir has got a lot of accolades and awards at by multiple societies. And he was, I think, one of the greatest, I would say, award which was granted out on him was the Outstanding Community Service Award by Indian Academy of Diabetes at Mumbai. So, sir, if you permit, I would want to pose a teasing question to you, and that is Dr. Anuj there?
Yes, sir is there. Sir is there. Sir, you
All
have
right. All right.
Yes,
Okay.
I am here. Hope you
Right,
can
sir.
listen me now. Yeah.
Yes, sir. Yes, sir. You were muted, right, sir. So I would want to ask you, sir, that what was the traditional place of a healer in ancient India? We call them doctors now, but essentially we were all healers during the traditional ancient time. We see that doctors today are being blamed for being too commercialized as doctors. Is it good? Is it required? Should we need to have a middle class path? Should we be more community oriented? So, and how do we place ourselves in the society? So, these are certain aspects I would want you to delve upon. Again, as we go along, the context of discussion is getting broader and broader. So, but I'm sure we'll learn a lot from you, sir, on this.
Thank you, Dr. Prafull, for inviting me in this meeting. Thank you, Shambhu, for giving me this opportunity. I have got an opportunity to listen uh, multiple speakers in this meeting, although I was occupied in another meeting also, but in between I was getting, so I was keeping the track after the Krishna Shishadri, and I was really very happy in my mind. This is the one of the best transformation in the medical science what anybody can and expect anytime. What are you saying about the place of the healer? It's really a very good question and very tricky also. Since from the ancient time, if we talk about the India, since from the ancient time and till the right time when we are in the practice, doctor or Vaidya, whatever you call, has always been equated to the God. And whenever we equate somebody with the God, we come into the sacrificing mode, not for from ourselves, but we accept all sacrifice from the other side. I don't know God is sacrificing or not, but whatever the examples we have with the God, may it be Lord Ram, may it be Lord Krishna, we have listened a lot of stories of the sacrificing, and always it is expected that because doctor is equated to the God, and doctor is the living God in this world. So he should do all sacrifices, may it be related to the money, may it be related uh, to the his routine lifestyle. If you are going to sleep, still you should be ready to serve the patient. If you are going on your traveling, then you should be available to see the patient. If you are busy with your family member, still the patient expect nahi, he should be given the preference. These kinds of the things we expect, we see in our day-to-day life that it is expected from a doctor or Vaidya, whosoever, whatever you. But in current scenario, world is changing, and you cannot take us back into the timeline. We cannot go back to the 1,000 year or 2,000 or 5,000 years before. If 5,000 years before, when our civilization was growing up, when at that time we were living in caves, we were wearing the leaves of the trees, we were using the medications from the in the form of the plant leaves or plant extracts. If we expect the same thing right now, many a times it won't be so practical. Many a times people will find how can it be possible that one can spend his life with the wearing the leaves. So these are the things which makes a person to think that hope I am audible.
Yes, sir, you are
Hello.
audible.
Yes, yes. So these things are there which makes a person always in the trouble, whosoever is working as a clinician or as a healthcare worker or as a doctor. If we really wish that current modern medicine is going to be complicated and complicated, and it needs the best brain should join this medical curriculum. If we really wish that best brain should join the medical science, then we should always make it lucrative like other profession also. Earlier, what was happening? Earlier, uh, a son or daughter of the Vaidya was becoming the Vaidya. Always, it was a family legacy which was being followed by the generation to the generation. So there were some family values, there were some family traditions, There were some traditions of the sacrifices which were being followed by generation to generation to the family. But nowadays, it is being a competitive atmosphere. Anybody can become doctor. Anybody can choose to become the doctor. And doctors are coming from the same society which is working, where we can see that a lot of people are coming in other job profiles, a lot of IAS are coming from the society, a lot of bank persons are coming from the society. So the society, whosoever having whatever the shortcomings or whatever the impurities in the form of the corruption, in the form of the other things, they are not, you cannot find that a doctor who is becoming, suddenly he will become the saint. If he is coming from the same society, he will be having the similar kind of the mindset what the other family members were having. Of course, we many a times we try to change them, we make them, but in our medical curriculum, do we really have enough time to give values to our medical students? Do we have enough time to teach them? We really don't have enough time out of the curriculum, out of the busy curriculum, out of the syllabus what we are teaching to them. So these are the things because of which lot of gaps are coming up between the people's aspiration and expectations and the performance of the medical practitioners in the form of the doctor. So definitely we cannot go back. We have to progress, and we cannot allow only to be this profession go into the people, those who are already practicing medicine. Everybody should be allowed to come in and join this profession. And we should always be ready to provide all kind of the development opportunities or progress opportunities in this medical profession also, as we provide in other professions. Still, the medical profession is bounded by so many limitations and litigations. Many a times we are not supposed to tell that this medication is good, this medication is not good. We are not supposed to tell that whether these guidelines are good or not. But otherwise, those people are not medical sciences. They are taking the name of our organization and our society. Last many months, I am seeing that one video is running into the social media, who is telling lot of wrong things about the American College of Physicians, that it has recommended this much for the diabetes, it has recommended this is the cutoff for the diabetes, which is absolutely wrong. But nobody is there, and we cannot come to the same level of the person who is giving the blames to our society. And people are telling everything. Now the social media is available, and this has made a platform where anybody can say anything about anyone. So these are the liberties which are in the hands of the people, but at the same time, when they are going into the hands of the wrong people, it causes a lot of harm to the society, and it is becoming the reason because of this conflicts which is arising between the medical professionals and the society many of the time, especially when the patients are not being survived despite the best efforts of the doctors and clinicians. So this is the thing which is coming up with the gradually developing world, and we must understand that we continue to provide the opportunities of the same opportunities of the growth to the medical practitioners what we are providing to the other professionals and other uh, uh, people, those who are working in other parts of the science and other parts of the livelihood. So these are the things what I really wanted to. I think I must I have been able to give you certain answer of your question. So if you still find that something is being lagged, you can ask me.
Thanks a lot, sir. Thanks a lot. Your your inputs were very frank and emphatic and clear, crystal clear. So, what I personally draw from your inputs is that maybe, if not commercialization, then some amount of professionalism is in order. It is in order for the sake of development of our field and for the sake of patients. But probably we need to work on our individual and collective communication. We also need to tell the outside world that if they expect saints and sages as modern doctors, then somewhere down the line they are going to get harmed. So health is a commodity which is the most costly commodity, and society will have to pay some price for it. But yes, we must have our moorings in the value systems, and I'm sure a lot of us have that. Almost every one of us has that, sir. But yes, frankly, sir, thanks a lot for putting such a complex, I would say, question so emphatically across to us. So thanks a lot for this, sir. And now we go on to our last speaker for this panel, and he is Dr. Shyam Sundar. Dr. Shyam Sundar is the Distinguished Professor of Medicine at Institute of Medical Sciences, BHU Varanasi. He's been a prolific writer. He has got 674 publications to his credit. That's more number of pages than most of the books would have, and with a H index of 107, which is rather big. He's been contributing to Harrison's Principle of Internal Medicine, Davidson's Principle of Practice in Medicine, two fundamental books which almost every UG student and PG student has read. Sir has also been the past president of Association of Physicians of India and Clinical Infectious Disease Society of India. We all know him as the leading force behind the elimination of leishmaniasis, and he is also ranked as #1 scientist in the world in this field from 2013 to 2023. So, if you permit me, sir, I would want to pose a little teaser question or initial question to you, and that would be that please sort of inform us briefly about your journey on tackling leishmaniasis and finally getting to eliminate that. That is one. Second is that over the past maybe 20, 25 years, the pandemics from unknown microorganisms, which were not very commonly known, appear to be increasing in frequency. So it appears to be cat and mouse game, wherein we develop some vaccines for a particular microorganism and then something else comes up. And a lot of times the origins of this new microorganism comes from the animal kingdom. So besides leishmaniasis and its success story, I would also request you to please tell us how do we harmonize our existence, that is the human existence, with other life forms, so that this kind of cross uh, infection, if I may use the term, do not take place. Dr. Shyam Sundar, sir, please.
Thank you, Professor Prafull. First of all, I must thank you and Dr. Sambhu for inviting me to be part of this webinar. I'm also very delighted Dr. Nilima Kshirsagar. With her, I have learned so much, and I've worked with her in some of our projects. So I think, let me tell you the story of visceral leishmaniasis in India, because I think Indian contribution is profuse in this field, and the earliest description of an epidemic of Kala-Azar or visceral leishmaniasis, the name itself suggests the Indian connection, Kala-Azar, 200 years ago, in early 1825 or something like that. Then the first description of a big epidemic is in 1858, where in Assam, thousands of people died of this disease, although it was not at that time known what it is, but the description was fitting into Kala-Azar. And the mortality was more than 90%, 95%. So there was no cure. Then the physicians, modern physicians, the modern medicine was growing. And people started using tartar emetic, a trivalent antimonial compound. Unfortunately, the side effect was so much that about 50% of the patients who took tartar emetic died. I must tell you the India connection. Professor UN Brahmachari in 1922 published a paper in Indian Journal of Medical Research where he said that, and he described first time urea acetopamine, a pentavalent antimonial, which had a cure rate of more than 90%. So from that 90% death to 90% life was the difference what Professor Yuan Brahmachari did in the city of Kolkata. And then it was in use, and it was at around 1937, it was replaced by sodium istibogluconate. So far, so good. However, in the new, and as I must tell you that in late 50s, the disease almost disappeared from India because of the extensive DDT spray against in the National Malaria Eradication Program. In early 70s, there was description, especially from Bengal and Bihar, the outbreaks of Kala-Azar or visceral leishmaniasis. And then, of course, the drug was available, but in mid 70s, it was some of the workers, they noticed that the patients are not responding as well they should. And this story went on. And so much so that in 95 onwards to 2000, many workers, including our work, we that only 35% patients are getting cured by this drug. About 8 to 10% patients are dying because of the cardiotoxicity. Because what happened, that initially the dose was very small in the earlier days. Almost 10 to 12 times more drug was being recommended and was used. And this probably led to severe cardiotoxicity. So in early 90s, we were really helpless. There was no drug. If a patient failed antimonials, sodium istibogluconate or istibonate, these patients, very few of them would get a drug which is called as pentamidine, which was imported from Europe, and the death rate was very high. Fortunately, a very renowned physician from North Bihar, Professor Mishra, he described amphotericin B deoxycholate he published first paper in 1991 and then published 3 papers. He described this drug, amphotericin B deoxycholate, initially when it was sold as fungizone. And this was a really saving grace. Unfortunately, this drug required 1 month hospitalization. You have to give 15 infusions every alternate day. So I was, I had become very interested. I was born in North Bihar, in Muzaffarpur. So we established a non-governmental organization, totally free treatment to patients with Kala-Azar, including food and etc. But what happened that initially we had 10 beds, then 20 beds. So you can imagine, we could treat only 10 patients in 1 month, 10 patients only with amphotericin B deoxycholate. And that was very frustrating. In every OPD, every weekend I used to go to Muzaffarpur. In one day, in one Sunday, I will see 40 to 60 Kala-Azar patients who required amphotericin B, and our capacity was only 10. Fortunately, over the years, we tried to increase the capacity, and today we have 80 beds. But so that was a very frustrating time when you have no bed, you have a drug which is very expensive, limited. These patients are so poor, they cannot buy the drug from the market, or they cannot have, have a treatment in a private setup, private hospital. Anyway, so this was quite frustrating. And, as a physician who is interested in this disease, and we had already found out, we made a breakthrough. Then when we got the diagnostic set right, so we could have a diagnosis of a Kala-Azar in 10 minutes by a very cheap, rapid diagnostic test using RK39 antigen. So I actually initially used ketoconazole, which was claimed by some of the eminent workers in India that it works against Kala-Azar. Unfortunately, in our hand, it did not. Fluconazole, another triazole. Then we combined etovaquone with fluconazole. These are all oral drugs. We wanted, I mean, there was no clue for a injectable drugs. So far, everything has been injectable in leishmaniasis, whether it is antimony, pentamidine, or amphotericin B deoxycholate. Then sitamakvin came. It was again an oral drug, but again it failed because it was toxic. So in 1996, we came across a drug which is known as miltefosine. It is an oral drug, first oral drug against leishmania. It was initially developed as an anti-cancer drug in Germany. But it had in vitro and in vivo, evidences of very effective anti-leishmanian drug. We started with a small, dose escalation trial, and in 1998 we published first paper in the Lancet of its efficacy, and in 2002 we published a paper in New England Journal of Medicine where we had shown that if we use this drug for 28 days, 50 to 100 milligram daily, this drug would cure 94% patients. And this was actually preceded by another paper in New England Journal of Medicine in 1999 we published. Then, of course, this drug was then, a Kala-Azar elimination program was launched in India, Nepal, and Bangladesh altogether. And this drug was with K39 rapid test being the quick diagnostic, followed by miltefosine for 28 days. And it went on, but miltefosine has had its own issues, and some of the signs of resistance started appearing. You have to give it for 28 days, so the non-compliance was very high, and then it could not be given to women of childbearing age group unless they practice contraception for the duration of treatment and 5 months, and that meant that you have to be very cautious because this drug was a potentially teratogenic, high incidence of GI side effects. So there were some negative points about this drug. At the same time, we came across liposomal amphotericin B, and this drug, and there were several preparations: amphotericin B lipid complex, amphotericin B colloidal dispersion. But I think liposomal amphotericin B, and the first description came from, the clinical description came from a drug named as Ambisome, which was produced in USA, in California. And this drug had a very high safety profile, very good safety profile. And this was actually initially developed, these liposomal drugs initially were developed for the treatment of fungal infections in HIV infection, severe HIV infections, where fungal infections were very common. So we started working on this. We initially worked on amphotericin B lipid complex, and then colloidal dispersion also, and Ambisome. And this Ambisome had an excellent safety profile. We started, and we saw that a 3.75 milligram of total dose of the drug given over 5 days would cure 89% of the patients. This was followed by, my desire was to develop a single dose treatment of visceral leishmaniasis or Kala-Azar. So we used 5 milligram single dose Ambisome, and this paper was published in 2002 in British Medical Journal. But see, looking at the cost of this, we are really disheartened that, but because the cure rate was only 91%, and it was not, not acceptable at that time, looking at a target product profile of 95% or more. Then we went on and we increased the dose to 7.5 milligram, no effect, again 90% cure rate. then we lost heart and we stopped using this drug for development. In 2007, WHO, with our publications, they discussed this with the Gilead Sciences, who were the manufacturers, and they offered to supply the drug at 8% of the cost. So initially the cost was $200. It was available at $16. So we became again interested. There was a gap of 5 years. And then we became again interested because now this drug was becoming relevant for our economy. Used 10 milligram dose, single dose again, for this, and it was a big trial. 304 patients were treated. We had a cure rate of around 96%, 95.7%, and the competitor was amphotericin B deoxycholate, where the cure rate was 96.3%, so hardly any difference. So WHO in 2010 recommended this drug. The good thing which happened was that the company, in their benevolent effort, they offered this drug free of cost to the Indian subcontinent. And that was, I think, one of the greatest move. This paper became a game changer. Then in the elimination program where miltefosine was there, it was replaced by single dose ambisome, 10 milligram, in all the 3 countries, India, Nepal, and Bangladesh. And in 2023, and there was a massive impact of this single dose, and there is no time so that I could explain you why. And then in 2023, Bangladesh became the first country in the world to announce, to be certified as have eliminated the visceral leishmaniasis in Bangladesh in 2023. In the same year, they were using all our instruments, diagnostic and treatment. And in 2023, again, India also achieved the target of elimination in all 633 blocks of the country, and which is now maintained. And the number of patients, say in 1992, would have been about 800,000, 600,000 to 800,000, and in 2023 it was 522 patients all over the country, and including Bihar, Bengal, Uttar Pradesh, and Jharkhand. So in 23 we did achieve the elimination. 24 we have maintained the elimination, and 25 I hope, and the figures are going down. In 23 it was 522 patients. This year in 24 it is around 300 patients. So we have actually been able to eliminate this disease, dreaded disease, I should say. And today you will be happy to know that of all the 84 beds that we have no patients. We get 1 patient in 2 months. So I don't want to go ahead. The story is long. I'll stop here, and then I'll come to your second question. Yes, I think we have to be very cautious, and the human and environmental interaction has to be, noticed, because I'm sure this, at least I don't believe that this came from Chinese laboratory. I think it came from a wild, and it got into human beings, and now, and this has not been proved as well. So I don't think I would blame Chinese laboratory, and we have to be very cautious. And if we can, like in leishmaniasis, if we are not very cautious, if we are not, there will be another outbreak. And we can have another 8,000 or 1 million patients. So this is what I wanted to say. If there are any questions, I'll be happy to answer. I just want to tell you that Dr. Nilima Kshirsagar has a great role. She produced an indigenous liposomal amphotericin B. But I think because of the bureaucratic, although I'm telling in public, but I don't care. because of the bureaucratic, environment that we have or we had. I don't know. I think the things have improved. We will be able to use Dr. Nilima Kshirsagar's. We have done a trial with a very good cure rate of Dr. Kshirsagar's amphotericin B, which is now known as fungizome. Unfortunately, we are not being allowed to publish the results because of the bureaucracy that we have. So thank you so much for inviting me. I'm glad.
Thank you, sir. Thanks for your very sagacious inputs. And personally, it's been a very engaging evening for me of having to engage with all these doyens and leaders of healthcare at various stages. And if I may, if Dr. Shambhu permits, I'll just summarize this entire thing into 5 lines precisely, which so one thing which we need to draw from our traditional source of knowledge are just 2 things. One is passion and second is perseverance. The road to solving our own problems is long, hard, but it is frankly doable. And it's not a single man or single person's do. India has always been a community nation. We have the basic unit in our system has been a family, then a village. So it's always been a community living in harmony with the nature around us. And I think that's what also, at the bottom of what we discuss lies these 2 3 things: teamwork, perseverance, passion, harmony with nature, other life forms, and of course some amount of bureaucratic ease would also hasten our journey. And while we remain moved into the service to society, we also need to ensure that this entire business of healthcare remains lucrative to people who are working with less lofty ideals and ideas, so that we keep on getting the best of the brains amongst us. And we need to learn a lot from our past. We should not untether ourselves. We should not cut that umbilical cord which attaches us to our path. And there's some fair ground of, I would say, some kind of co-learning or co-training between these 2 areas. Yes, sir. Sir, you wanted to join something, sir?
I just want to say one point. I am a great believer in Ayurveda. And believe me, if I believe in something, I don't treat any patient who has got anorectal disease or who had got say things like piles and fissures. I immediately send them to our hospital, Ayurveda hospital, Charsutra Clinic. My firm belief is that we should develop the Ayurvedic drugs so that the Ayurvedic physicians they believe in their own drug.
Yeah.
I think biggest killer of Ayurveda, I think, is the non-belief of the Ayurvedic physicians or Ved in their own system. And I think we really, if we can have something like ICH guidelines and we follow the Ayurvedic medicines, and if we are made to believe it, I mean, if we can believe in a publication from USA, why not from India? And why not use the Ayurvedic drugs? So that's my feeling. Thank you. Sorry for.
No, not at all, sir. Not at all. In fact, this is something which we would have missed otherwise. And thanks for pointing this out to us, that we need to have our own rigors in place, and we need not jettison anything, need not leave anything. Only we need to sort of test the traditional systems as per the modern, more translatable, parameters. So, Dr. Shambhu, I think we are at the end of this panel discussion. It's been fantastic. If you, as a coordinator, want to ask any of the panelists any question, the mic is all yours.
Yeah, no, this is a fantastic panel discussion, and really a great salute to you also, because as a moderator, you have done a fantastic job. If before we move towards the last event of today's session, if our respected panelists have any final comment, please unmute yourself and tell us about your final comment on today's discussion.
I think this is Shyam Sundar said rightly You need to make a Ayurvedic way of diagnosis, number one, standardize the drug, number two, but for the research purpose, you need to translate this into the terms of modern medicine, the basic sciences. And if you do so, then you can reach up to the expectation. Because I wrote a review on Sencona, this what dalchini, what we call dalchini. This is one of the like we use on our food preparation, and I got a paper to review it. And there was almost more than 300 papers from US and neighboring countries. So the amount of work which is being done on this particular plant, which is available whole of the world, like Apple. Apple has, we now today understand SGLT2 inhibitors come from the apple bark. It has the drug has a role, its presence into the apple bark, into the sheath, into the pulp, into the seed, as well as into the peel of it. So many action have been published, but we really do not standardize them scientifically. We need seriously to look at and develop a discipline where all these drugs would be tested on modern parameters, then can be translated into modern therapeutics. Thank you.
Absolutely, Dr. Saab, you have just echoed my views. Thank you so much, sir.
Thank you.
Any comment from Rege, madam?
What I feel is, can you hear me? What I feel is that Ayurveda is our science. And if we have to bring these drugs on the global platform with, as Sir rightly said, generating evidence using appropriate research methodology. I will not say modern or ancient. It has to be appropriate for that and acceptable by those our peers, scientific peers. We are the one who have to do it. We can't rely on the other countries that they will bring it and then we will use it. We have to take up as a mission, and we have to, as we are doing so much of research on other drugs, our modern drugs, we should also start doing research on our own drugs and at least see to it whatever is mentioned in Ayurveda, whether it stands stands the test of time today, or there are some changes are required because lot many things have changed. Our technology has changed. The plants are different. We have changed. There is an evolution. The dose may not be the same. So there is so much to do for these things, but it is we Indian scientists should do it.
Absolutely.
Thank you, madam. And now may I ask Professor Nilima Kshirsagar, madam. Madam told about Professor R.N. Chopra as we know that father of pharmacology, father of clinical pharmacology in India. I think many of us, your student, we can say, we see you as a mother of clinical pharmacology. I think it is a real pleasure to have you with us today, madam. So your final take on this important topic, madam.
Thank you so much, and I'm absolutely embarrassed and with all humility, I must say that I've learned such a lot in today's seminar. I should really congratulate you for organizing this. I was also a bit skeptical as to how we will take this entire webinar, but thanks to you for organizing it so well, and also to Prafull for doing a great job of putting the questions to all the panelists. I would say, as has been mentioned by everybody, that to be able to, there is a wealth of knowledge, and our country has so much of biodiversity. And what we have in Ayurveda, that's, we have, as you said famously, that you have to do one experiment to convince yourself, but you have to do 100 experiments to convince the others. So that is, if we have to convince the non-believers, as one may say, we need to really make sure that we put the rigors of modern science. But as has been said by others, take the knowledge from Ayurveda Well, I think that is something, and I find that the great role of the clinicians who are here, who have so much of great experience, and along with them, with the pharmacology and clinical pharmacology, combining the traditional knowledge, is, I think, the way forward. And as Dr. Shyam Sundar mentioned, we hope that the bureaucracy in full-fledged support this all and provide us the funding for it, which is where sometimes we, I think, lack giving the insight. So, but thank you so much for this.
Thank you, madam. Thank you. So we have also with us Padma Shri Professor Shashank Joshi, sir. Sir, your insights on today's
I
topic.
think overall, even the panelists gave some very good insights, some original research from Professor Rege, Professor Shyam Sundar. Madam Nilima has been a teacher of teachers. Prafull did a great job, Professor Kamalakar Tripathi, Anuj, and very, very ably supported by Jyotirmay, Paul and Nandini. Shambho, congratulations, keep it up. And let's do some more science and evidence, which can make some of these things which we discussed today as a level A evidence. So I think we really need to do some good science. And let's hope, as Madam Kshirsagar said, that we get little more funding from governmental and non-governmental agencies. But I think we have a will to investigate and do some research questions, and we can move forward on that. So congratulations to you, and I think it is a very good initiative by you, Shambho, and ably supported by Jyotirmay and Nandini and the entire API group. I think you can do a lot in this year. So thank you so much for the opportunity.
Thank you. Thank you once again, sir. So now may I request our scientific convener of EPICON 2025, Professor Nandini Chatterjee, madam, to have her concluding remarks.
Thank you, Shambhu. And a very good evening to our esteemed speakers, panelists, and participants. We are drawing to a close this enlightening session on spirituality, science, and skill, the triple helix of holistic healing. And we have aptly celebrated the Vivekananda Jayanti, where all our esteemed speakers have merged ancient wisdom with modern medicine and how we can have our paths merged and progress to the future. I take this opportunity to thank all our speakers, Dr. Jyotirmay Pal, Dr. Shashank Joshi, Dr. Krishna Sheshadri, and last but not the least, Dr. Shambhu Shamazdar, for having such an interesting discussion on this profound subject. The panel discussion on bridging ancient wisdom with modern medicine also provoked a lot of thought, and the excellent deliberations by Dr. Nirmala Rege, Dr. Shyam Sundar, Dr. Kamalakar Tripathi, and Dr. Nilima Kshirsagar deserves special pranam and mention. Skill without science risks becoming misguided, and science without spirituality may lose its humanity. Spirituality without skill, again, can lack practical relevance. So all the lessons that we have learned from today's discussions, I hope it will help all our listeners and illuminate their professional journey. I also thank all the participants, the audience, who have joined us for this beautiful program, which has been put together and is the brainchild of our dynamic Shambhu. I thank you all, and good night.
Thank you very much and good night.
Thank you. So thank you all. So we will have one national anthem now, as we are celebrating Swami Vivekananda's birthday. So may I request our technical team to start the national anthem, and I request all the delegates who are attending, please stand up for the national anthem. So technical team, please start the national anthem. Any difficulties from the technical team?
Yeah, yes, sir. So should we play that video now?
Yes, yes, please.
Okay.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you all. So
Thank
good,
you.
good night. Good night,
Thank
everyone.
you. Good night.
Thank you.
So good.
So thank you so much, everyone, for giving us the opportunity to host this session. So with this, we are concluding today's session over here and looking forward to host you
If
again.
you have any video, you can start. Your Klarnet, you have
No,
not?
sir, we do not have as such videos till now. Thank you, sir. Good night.